So I'm starting our recording. Today we're going to be doing chapter 19, which is Doppler. We've been kind of doing Doppler bits and pieces really since last semester. So a lot of this stuff you guys already know. It probably already makes sense to you, but we're going to get into a little bit more of the physics components to it. So we do have an equation that we're throwing in there. The Doppler equation is something that our registry really likes to test us on. So this is information that you will see both on your physics registry and then also on your vascular registry if you plan to take that in the future. So this information will all be coming back if you do decide to take that down the road. So what is Doppler, right? We can use Doppler for really anything. We use it for weather, right? We use it for radiation, but for us, we're using this to really precisely visualize and measure the velocity of a moving fluid. And in our case, in clinical ultrasound, that's going to be blood flow, right? Blood moving during circulation. So that's what we're using Doppler for. We already know that, right? We do so by evaluating what's known as the Doppler shift, or also known as Doppler frequency. So basically, when you have blood flow in a vessel, whether it be an artery or a vein, you are looking to see that relative exchange or that relative motion between our transducer and the vessel. So between our sound source and the receiver. So this is something that is going to be changing, right? Because you have a vessel and it is moving, kind of like M mode with the fetal heart, where we're looking to see how that distance changes between the transducer and the boundary and the reflector. This is kind of that same concept, but we're doing so more with the frequency and not the motion. So we look at this by what's known as that Doppler shift. So the frequency is going to basically change during this exchange. The blood vessel itself, that moving blood flow through it, it has its own velocity, right? It has its own speed and direction that it's traveling in. Therefore, it's going to put out its own frequency, regardless of what our transducer frequency already is. So we need to take into consideration that exchange of what is happening when our sound source, when our sound wave is hitting this vessel that's putting out its own difference in frequency. So if we are looking at tissue, right, our tissue is not moving, it's not changing, it's not pulsating. That frequency is going to stay the same, right? It's just going to be the frequency of the transducer, the original frequency, right? And it's going to have its natural behaviors that normally happen when we're using just regular sound waves and regular 2D grayscale imaging. But when we're looking and using Doppler, we are now saying, okay, somewhere along this pathway, there's going to be a change in frequency, and we need to pick up that change. We need to pick up that Doppler shift. So what is that, right? How can we figure that out? What are we talking about? Well, basically, when we're using Doppler, we are sending in a low frequency that rides on top of that transducer's frequency. So we're basically saying to our system, hey, there's along the pathway of this sound wave that we're sending in, we want to be able to pick up a difference in frequency. And that's what our Doppler display is going to be. So for example, if we use this example here, our transducer sends in a frequency of 5 million hertz. Right? It's traveling, it hits an artery, right? So it's going to hit those moving red blood cells, it's going to hit those moving blood flow, and it's going to reflect back to us a frequency that's different, right? Because that artery has its own frequency naturally. So now this reflected frequency is now 5 million, that should say 3,000 hertz. So the Doppler shift, or that change, is positive 3,000 hertz. That's what we are looking for when we're using Doppler. We want to see, is this exchange positive? Is it negative? And we want to put a value to that. So we do so by calculating that Doppler shift, that change in hertz. So that's our reflected frequency, the frequency that's going to be sent back to us after it hits that moving vessel. And we're going to subtract the transmitted or the original frequency from that to get that change in frequency. So like we said, we're looking to see, is that change positive or negative? And that's going to determine the direction of that blood flow. So So a positive Doppler shift is when we have a reflected frequency, so coming off of that moving vessel or structure, and it's going to be higher than the original frequency from our transducer or our original sound wave. So this means that our red blood cells are moving towards us, moving towards the transducer, because we're having a positive shift or a positive change in that frequency. When we have a negative Doppler shift, this is when the reflected frequency is going to be lower than that original sound wave frequency. So this means that our blood cells are moving away from the transducer. So they're going even farther away from us, making that frequency even lower, or negative in this case. So it's important for us to also remember the difference between speed and velocity. This was from one of our very first PowerPoints in this class. Doppler is going to display frequency and velocity. So it's not going to give us speed. Speed, the difference of that is it's indicating a particular distance. So how fast did something travel in 1 second, right? Or what was the distance that something traveled in 1 second? We're not putting a particular time frame on that when we're using Doppler. We're looking to see that exchange, and we're looking to see that positive or that negative change in that Doppler shift, right? So to tell if the blood cells are moving towards us or away from us, and then also the value to that. So what was that change? What is that numeric value? And that's going to be our magnitude. So this is really giving us a velocity, which is the magnitude and direction. It's not giving us a speed because we're not confining it to just a 1 second time frame, and particularly talking about distance. We don't really care about distance when we're talking about blood flow in ultrasound. We care about the direction of flow, and we care about the strength of that flow. So here's our equation that we are going to be using for our exam. We're also going to be using for our physics registry. This is how we calculate that exchange or that difference. So our Doppler shift is when we take our velocity of the blood flow, we multiply that by the transducer frequency, so that original sound wave, multiplied by cosine, multiplied by 2, the whole thing combined there. And then we're dividing that by our propagation speed. So a lot of this information is going to be given to you in a particular scenario or circumstance. So you just need to remember this equation so you can plug in all of that information. And remember that we are looking for units of hertz with this Doppler shift. So we want to see the difference in frequencies when our sound wave is hitting a moving vessel. What is happening to our sound wave once it hits something else that's already moving and putting out its own frequency? Are those frequencies going to combine together, or are they going to subtract from each other? So the Doppler shift is going to be directly related to the velocity of that blood flow. So the faster the velocity, the greater the Doppler frequency or the Doppler shift. So next we have our units here. So we have hertz versus centimeters per second. So we sometimes will see centimeters per second on our display screen. Sometimes we're seeing hertz on this other side of our screen. So we need to know what information is being displayed to us and what units are assigned to that. So if our Doppler shift is measured with units of frequency, how are we going to measure the velocity of blood? Because velocity is measured in centimeters per second. And as we just said, our Doppler shift from our Doppler equation is telling us frequency, so hertz. Our ultrasound systems measure the frequency difference between the received and transmitted waves, and then the Doppler equation is actually going to be programmed into the system, and it displays the velocity of blood by calculating the frequency of that information that it's processing. So our machine is kind of bouncing back and forth between the information that it's getting and then the information that has to be displayed on our screen. So the system is going to receive the information in hertz, and then it's going to convert it into centimeters per second to be visualized on our spectral analysis. So if we look at this example here on the side, we have our spectral analysis and our spectral window right here, where we can see our waveform. But then if we look right here on the side, This is our scale. This is our Doppler scale, and it's showing us the velocity. So it's giving us centimeters per second. So this is the range of velocities that we're telling our spectral analysis or our spectral window to display within. So this is going to be mainly our velocity information on the side over here. And then if you look on the left side, we see all of our other information over here. Now, a lot of this information is very complex and it's very different on each machine, but it's telling us that our original frequency is 4 megahertz. We also have a filter right here, which is coming in at 100 hertz. So that's not really something that we'll talk too much about today, but you can see that there is a portion on the side of our spectral analysis or our spectral window when we're Dopplering that shows us that original sound wave information. So we don't need to necessarily do anything about it, but this is where we can see all of our information, the original information on that left-hand side there, and then the converted information to velocity on the right-hand side with our Doppler scale. So continuing on here, so what is the relationship between the transmitted frequency and the Doppler shift? Transmitted frequency, remember that's our original frequency of that sound wave. The Doppler shift is directly related to that frequency of the transmitted sound, so our transducer frequency, and it's also going to be directly related to the velocity. So as our velocity increases, so does our positive Doppler shift. Okay, so sound beam direction versus flow direction. So this is where what we do in terms of how we scan a vessel matters. It can really play a role into the accuracy of our waveform when we're Dopplering. So measurement of Doppler frequency depends on the relationship between the direction of the blood flow and the direction in which the sound wave is traveling. So our artery can be traveling in one direction. We can't control how that artery is traveling or the direction that it's traveling in. What we can control is how we direct those sound waves and how we will have those sound waves travel within the body. So you guys hear me constantly saying, we're going to heel toe, we're going to sweep up, we're going to rotate, right? And that's because we want to match the direction of the vessel. We can't control what the vessel is doing. Yes, we can alter the patient's position, but ultimately that vessel is going to travel how it wants to travel. We can adjust how we scan to match that direction. So when our sound wave is parallel to the blood vessel, right? This means that the blood cells are moving nicely parallel to our sound beam. The entire velocity is going to be measured accurately with this. There's no other factors that will play into it when we are completely parallel to our vessel. This means that the red blood cells, that blood flow, they're moving either directly towards the transducer or directly away from us. So if we're coming in perfectly parallel, the velocity that we Doppler, and when we measure that waveform on Doppler, that measured velocity is going to be 100% accurate. Now, when we come in at a little bit of an angle to that vessel, then we're not getting the true velocity. So we're taking into consideration beam divergence, absorption, all of the attenuation. We're taking into consideration all of those other factors that happen to our sound wave, more so when we're coming in on an angle, because we're not 100% parallel to that vessel. So we're not getting the true information on how that waveform is actually behaving. So we want to be as close to parallel as we possibly can in order to get accurate velocity measurements. Now, sometimes we just can't get that parallel angulation to the vessel because the human body, like we said, is going to do what it wants to do. In some patients, it's a lot more difficult to get that. So we need to take into consideration when we are coming in on an angle for our Doppler. Just because we can't get parallel to a vessel doesn't mean we're not going to do the exam, right? So we need to take into consideration how we can account for any type of angulation between our transducer and our sound wave and then the vessel that we're trying to evaluate. So if the sound beam and the flow direction are not parallel, what determines how much of that velocity is going to be measured? As we just said, when we're not perfectly parallel, we're not getting the 100% true velocity of that vessel. So what percentage are we actually getting? The percentage of the true velocity measured is going to depend on the cosine of the angle that we're coming in at. So the angle between the vessel and the sound beam. So we need to take into consideration, okay, am I coming in at more of a 30-degree angle? Am I coming in at a 60-degree angle? If I'm 90 degrees, then I'm perfectly perfectly perpendicular. So how much of an angle am I coming in at? So we can calculate this by our measured velocity is going to equal our true velocity multiplied by our cosine. So here is our little chart as well to give us the units that we would use to calculate that. Okay, so here, continuing on with that angulation that we would come in at for our vessels, we can never, depending on the artery that we're looking at, we will rarely come in at 100% parallel. So this is why coming in at an angle is important, because we need to figure out which angle is best to get closest to that true velocity as possible. So using that previous equation on the slide that we just went through, figuring out what angle is possible for us, right? So what angle can we actually obtain? And then how does that angulation correlate to the blood vessel that we're trying to look at? So if we were to try to come, before we even get into information on this slide here, if we were to try to come in perfectly parallel to this blood vessel, we can't, because if this is the patient's skin surface, here's the patient's blood vessel, I mean, where would we have our transducer? Flat on the skin, and we wouldn't even be able to send that sound beam in properly. So this is why we're using some type of angulation to get the information that we want. We just need to be aware of that relationship and cosine and all of that. So Doppler shift and cosine. So the relationship between these two, the Doppler shift is directly related to the cosine of the angle between the vessel and the sound source. So the Doppler shift and that angle are going to be directly related with cosine. The actual velocity and the measured velocity when the beam, when the blood moves parallel to the sound beam, this is going to give us our 100% true velocity. But again, really hard for us to get perfectly parallel to a vessel in the body. So actual and measured velocities when the blood moves perpendicular to the sound beam, this is going to be a velocity of 0 because the cosine of 90 degrees is 0. So if we look back on this slide right here, when we're perpendicular to each other, our cosine is 0. So anything multiplied by 0 is going to be 0. So we want to get some type of angulation as close to parallel as we can. We don't want to be perpendicular to a vessel. So if we are coming in perpendicular to a vessel, so 90 degrees, right? That's going to be this example here. The cosine of that is 0. So the information, the accuracy of that velocity is going to be null and void. We're not going to get any accurate information. And if you've seen me in lab when we're trying to do vessels, I tell you guys to heel toe, right? To get more of an angle on that aorta. Our proximal aorta goes up the screen and then mid kind of goes flat, but distal comes back down the screen, right? Even when we were doing legs, we don't want to see that sagittal vein straight across our screen, because when we go to put our color and our color Doppler on, we're not going to get really any flow that comes in from that 90-degree angle. We need to have some sort of variation. We need to have some sort of angulation. So if we also look at this example, this would be the waveform that we would get sampling a vessel completely perpendicular or at 90 degrees. So it's not an accurate representation of what that blood flow actually looks like. Now, if our blood flow, this diagram is telling us it's traveling this way, if we're sampling it on a steep angulation over here, we're angling it down into the vessel, that blood flow is saying that it's traveling away from us. So we're going to have a negative Doppler shift, and it's going to appear below the baseline. Now, if we are evaluating the same vessel, the direction of our blood flow didn't change, but we come at it this way, so we have the same angulation but different direction, well, the blood flow is now coming towards us. So now that's going to be a positive Doppler shift, and it's going to appear above our baseline. So the way that we approach a vessel is really, really important, and we need to be aware of all of these factors to make sure that everything lines up perfectly to get as close to 100% accurate information as we possibly can. So bidirectional Doppler. So this is what we are looking at when we are doing any type of Doppler of a vessel. So it's going to help us to distinguish the direction of flow towards us or away from us. So as we said, that's either going to be a positive Doppler shift or a negative Doppler shift. Positive towards the transducer, negative away from the transducer. We also are doing this with a visual display, right? That's how we're actually seeing it on our screen. And as we know, when we're Dopplering an artery in particular, we're getting that audible noise that is being displayed as well. So you can turn that volume up, down, you can turn the volume off. We like to kind of keep it on just so that we can confirm that we're either in an artery or in a vein. Some machines you may use headphones or speakers connected to the system, but most ultrasound machines, as you guys have seen, are going to have speakers built right in, and that's where the sound is going to come from. And then visually, our waveform or our Doppler shifts are going to be displayed as a graph, as we said, with our X and our Y axis. Above the baseline is going to represent a positive Doppler shift, so towards the transducer, and below the baseline is going to represent flow away from the transducer or a negative Doppler shift. So we're all pretty used to seeing this right here. Nothing new there. Now, continuous wave Doppler, this is something that we don't use clinically in ultrasound, but echocardiography uses continuous wave Doppler very frequently. It's a different transducer. It's a different type of Doppler principle, but what it does is the transducer has two crystals in it, and one is constantly transmitting sound waves and the other is constantly receiving. So in the transducers that we use, we know that there's a talking time and a listening time, right? With a continuous wave transducer, one is constantly talking and one is constantly listening. So there are advantages to that, but there are also disadvantages to that. And this is why we don't use this really in general ultrasound. It's kind of mainly for echo. The advantages are really able to accurately measure very high velocities. And if we think about why that's good for echo, our heart is the generating source, right? So we're going to have really high velocities at the heart and near the heart. So we want to be able to accurately measure those. Disadvantages, we can't determine the exact location of where we're sampling that velocity from. That velocity is going to arise kind of from a particular region, and this is known as range ambiguity. So it's not giving us a precise location of where we're getting that sample from. In an echo, that's okay because there are all these different chambers of the heart that they're trying to evaluate, and they want to be picking up all of those high velocities from those regions. So the particular location, the precise location, is not as important for echo, whereas for us, it's really important because we want to be precise in saying where we're sampling this blood flow from or this waveform from. Okay, so pulse wave Doppler, this is what we're doing. You do need to know continuous wave Doppler for your physics registry, and you do need to know that that is the difference between general ultrasound and echocardiography, but we are mainly focusing on our pulse wave Doppler. This is when we are using our regular transducers. So we have our crystal that is talking and then listening. There are advantages of that and of course disadvantages. Some of those disadvantages, we're not able to accurately measure extremely high velocities. So someone was telling me last week in lab that they saw their first carotid stenosis, and those velocities can get really, really, really high into the 600, 700, 800 centimeters per second range. And our transducers are going to cap out at a certain point. So if you have an extremely high velocity, our system is going to say, I'm sorry, I can't help you after a certain point. So our high velocity flow is going to be incorrectly displayed, and it's going to almost look like it's wrapping around our spectral window. So it's going to be looking like it's traveling in the opposite direction, because it's going to come up and around the top of our waveform to now be on the bottom of our baseline. And if we remember from our abdomen Doppler lecture, that is known as aliasing. So that is not an accurate representation of really, really high velocities. The advantages of using pulse wave Doppler for us is going to be giving us a precise location of where we're sampling that velocity from. So this is that range specificity. So, the use of a sample volume or sample gate is really important for us. So when we're Dopplering a vessel, I tell you guys, put that sample gate right in the middle of the vessel, right for that parabolic flow where we get the highest velocity, in the middle part of our lumen or the middle part of our vessel. So it's a small marker that we actually position on our image to indicate the location of where we want to sample that velocity from. The system is going to calculate all of that information depending on where we place that sample gate before it starts to listen for a reflection. So it's calculating all of that information before it actually needs to receive that information and process it. So that is going to be a definite advantage for us. So this is just a general picture of our pulse wave Doppler. Here is our spectral window or our spectral analysis. We have our velocity scale on the side here coming in at centimeters per second. And then if we look at our picture, we can tell that we're using pulse wave Doppler because we're getting our line, right? Our scan line right here. And then this little guy is our sample gate. So this is what we want to be aware of, where we're placing it, because that's where we're going to be picking up that information from. We want it nice and centered in our lumen to pick up that highest velocity on parabolic flow. We also want to make sure that we're not too close to the wall, right? Because then we're going to get some of that slower velocity of that waveform. And then you can also adjust that sample gate as well. So if you have like a really, really tiny vessel that you're trying to look at, you can make that sample gate really narrow. If you have a wider vessel, or you want to maybe pick up more of a range in terms of the velocity within the vessel, you can make that sample gate a little bit wider. We're not adjusting the width of the sample gate too often, but that is something that you can do depending on how precise you want to be in terms of measuring a particular velocity. Okay, so aliasing, we have learned about this before, but this is going to be the most common ultrasound Doppler error. It's very easily adjusted for, so as long as you know how to adjust for it, that will come second nature to you. So aliasing is going to be caused by high velocity measurements that start to become displayed as traveling in the opposite direction. So you have our, we know as a standard that flow above the baseline is traveling towards our transducer, positive Doppler shift. Flow below the baseline, traveling away from our transducer, negative Doppler shift. When you have a velocity that is so high that it reaches the top of our display, it's not going to stop, right? It's going to wrap around the top of our display and come around the bottom to be displayed as a waveform coming below the baseline. So the very top of our display, or our spectral analysis, is going to be known as the Nyquist limit. We remember this from a few weeks ago. And then the flow wrapping around the bottom of our display is when we classify this as aliasing. So both of these examples showing aliasing, right? We have our baseline here. We have our arterial waveform above the baseline, but it's so high, it's beyond our Nyquist limit, right? Which is going to be our 20, because that's the top of our scale, that it's wrapping around the bottom. And we're seeing that peak velocity on the bottom of our baseline when it should be on the top of it. And same thing over here, our Nyquist limit is going to be 15 in this case. So of course this peak velocity is much higher than 15 centimeters per second. So it's wrapping around the bottom here. So of course we don't want to be using those as images. They're non-diagnostic, they're highly inaccurate, so we need to be adjusting for that. So our Nyquist limit is the first thing that we need to evaluate and see what's going on with that. Basically, the Nyquist limit is known as our speed limit, right? So this is what we're telling the system listen, this is the top velocity that I want you to display. I don't want you to display any velocities faster than this. So this is the limit. This is where I'm capping you off at. The vessel, like we said, is going to do whatever it wants to do. It has its own frequency. It has its own velocity. So that vessel, that velocity in that vessel is going to say to us, yeah, I don't care what speed limit you implemented. This is the speed that I'm traveling at. So figure it out, deal with it, right? So the limit, when we're calculating our Nyquist limit, is going to be 1/2 of the PRF of that waveform. So we can actually calculate what our Nyquist limit should be. Our Nyquist limit, although it is adjusted by our Doppler scale, which is in centimeters per second, the Nyquist limit is processed before that, right? So before our system converts all of that information, the Nyquist limit is still going to be in hertz. So we need to be aware that the Nyquist limit is focusing on the frequencies, right? The maximum frequencies, although it's being displayed to us once it's already processed into centimeters per second. So if you go back to those first few slides of this PowerPoint, that's why we kind of need to know the relationship between velocity, centimeters per second, and frequency, hertz. So the effects of our gate position, where we place our gate is really important, right? We want it nice and centered in the vessel. But when we have a vessel that's really deep in the body that we're trying to sample from versus a vessel that's really superficial or shallow in the body, this is going to affect that information, right? So when we have a deep sample gate or a sample position, our PRF is going to be really low. So our Nyquist limit is going to be low. The velocity is going to be sampled less times per second, right? Because the deeper we travel into the body, we can't process as fast. So it's not as accurately going to measure higher velocities deeper in the body. So then we're going to get aliasing. So as that sound wave travels deeper into the body, that speed limit is going to just naturally lower and lower and lower and lower because our system can't process that information as fast, right? Now, when we have a superficial vessel that we are sampling, our PRF is much higher, right? So our Nyquist limit is going to be higher. So the velocity that we can sample is going to be higher. So if you think about Dopplering an aorta versus Dopplering a carotid, your carotid is much more superficial than your aorta is, right? So our Nyquist limit, our speed limit, is going to be higher with the carotid because it's more of a shallow sample position where we're putting our sample gate, so we can process that much faster. It also helps that usually our superficial arteries are much higher in velocity. Our aorta is actually going to be a little bit of a lower velocity because it's under so much pressure. We'll learn about that in the fall. But it actually helps that we have a higher Nyquist limit for carotids because carotids are prone to having really high velocities. So it's a nice relationship that we have with those primitive physical principles. So how do we adjust for aliasing? There are 5 steps that you need to follow to correct aliasing. A lot of times you will see a technologist adjusting the baseline first, and that is an important step that you want to do, but you first want to look at your scale. So the first thing that you should do when you see aliasing, your eyes should pop right over to that scale on the side, your Doppler scale, and see what is your limit set at. What is your scale set at? So if you have aliasing, your speed limit is too low. So we need to be able to up that speed limit. So we want to be adjusting that scale in an increased fashion. So we want to be setting it higher, set your scale higher. Once your scale is appropriate, we then want to say, okay, can I sample this vessel from maybe a different window with the shallower gate placement? So can I, I'm looking at the aorta from the anterior aspect, and it's really, really deep in the body. If I come coronally, can I get that aorta to be positioned a little bit more superficial to get my gate placement more superficial, right? So my Nyquist limit can be higher. So the velocities that I can process and display can be higher. If you can't get a new window, or say you're even scanning a really superficial vessel and you're still getting aliasing, well, you know it's not your gate placement. You can't get anything more superficial. Then we want to look at our frequency. So we want to say, okay, I'm using a 3 to 5 megahertz transducer. Can I select a lower frequency? Am I using the 5 megahertz of this transducer? Okay, if I am, then I want to drop that lower. I want to use a lower frequency if possible. And then I want to look at my baseline, right? So I want to adjust my baseline after I've done all of those first 3 steps. And if adjusting my baseline still doesn't work, do I have a continuous wave transducer available to me? Do I have an echo probe available to me? If I do, then I can use that, because we just said continuous wave transducers are great at measuring high velocities because they have a crystal that's constantly sending and one that's constantly receiving. So your instinct as a technologist is going to be to adjust the baseline first. And that is a step, but that should not be your first step, because adjusting the baseline is not going to edit any of the information or processing of those sound waves. We want to edit those sound waves first before we just start moving the baseline up and down. So we'll talk about that in a second. So the first step that we said to adjusting for aliasing is going to be looking at our scale. So what is our speed limit set at? What is that maximum velocity that we are going to be displaying set at? Clearly it's too low if we're aliasing, right? So we want to increase the scale to maximize our PRF of those sound pulses, because when we increase our PRF, we are increasing our Nyquist limit, so therefore we are going to be increasing our scale. Increasing our scale, everything is going to be have more information processed. So that's going to be a great advantage. So the advantages of adjusting our scale are increasing our Nyquist limit is going to reduce the possibility of aliasing, but the disadvantages, when we're increasing our PRF, it's going to result in decreased sensitivity to some of those lower velocities. And again, with really, really high velocities, sometimes it's just way higher than our system can process. It's way higher than our scale's maximum is. So sometimes when we're getting a velocity of like 700, 800 centimeters per second, that's just too fast for our system. So, we would need to do a little bit further evaluation with that. And if we look at our examples here, we had a 20 centimeters per second maximum for our scale in that top diagram. And then we changed that, we increased that to 40. And then we reduced all of that aliasing. So our second step, as we said, finding a new window for where we are sampling our vessel from. This is actually a fetal umbilical cord that we're sampling this from. So some advantages to this, as we said, when we move our sample gate or we move our vessel more superficial, it's going to increase our PRF and it's going to increase our Nyquist limit. So we can continue to increase that speed limit for these vessels, and that's how we're going to decrease our aliasing naturally. There are no disadvantages to this. So this is a really good step that you should take if possible. But usually if we're struggling to get a good window for a vessel, we're going to have a hard time trying to find it in a more superficial window. Next step is going to be to lower our frequency transducer. So the Doppler shift is directly related to the frequency of our transducer. The disadvantages to this is that lower frequencies are going to produce lower quality images, especially as they continue to travel. So deeper images are going to be a little bit, superficial images are going to be a little bit more challenging with the lower frequency transducer. We will get more penetration with that lower frequency, but that superficial imaging is going to be a little bit more limited because of that. The advantages is that lower frequency waves are going to reduce the height of the Doppler spectrum. So again, having a secondary influence on that Nyquist limit. So if we look at this example here, when we have that lower frequency transducer, we are getting that lower frequency wave. Whereas when we're using the higher frequency transducer, we're getting that really high velocity, but it's over that limit. So when we're using a lower frequency transducer, we're kind of minimizing that information. Okay, so next we have our baseline shift. So this is going to be something that you want to do right away, but please make sure you're adjusting your scale first and using those other steps before this. So when we're doing this, we're really just moving the baseline up or down. So the advantage is our measurements are going to remain accurate. Our aliasing is going to be adjusted by moving the baseline down, and the velocities are going to be displayed in the appropriate direction. We're not changing any of the information that's being processed. So the disadvantage to that is that we're not changing the Nyquist limit, right? So we can't adjust for a high velocity waveform that's creating this aliasing. So if you have a low velocity waveform or a low frequency waveform that is creating aliasing, you can move that baseline down and chances are it's probably going to be fine. But if you have a high velocity waveform that's creating this aliasing and you just move your baseline down, you're just going to be either covering up the aliasing or you're still going to be getting it. So we can't really adjust any of the information to be more appropriate when we're just adjusting the baseline shift. We're not changing any information. We want to change information in order to adjust that speed limit. So we want to be aware of that this is a quick fix. This is kind of a cosmetic fix. It's not going to be the best fix. So if you look at our examples here, we have our baseline here. For the first one, we're getting aliasing. So then all we did was move that baseline down, and now we're seeing the whole peak velocity of that waveform in our spectral analysis. Okay, so continuous wave Doppler, this is going to be our last step. Chances are we're not going to be using an echo probe. Chances are we probably don't even have an echo probe. But aliasing never occurs with continuous wave Doppler because one is constantly sending, one is constantly receiving, and they are able to process extremely high velocities. But as we remember, the disadvantages, range ambiguity, we can't pinpoint right where we want to sample a velocity from. So we're getting an average of velocities in a particular range. So it's going to be an inaccurate velocity measurement. Yes, it's going to give us high velocities. It's going to give us information on high velocities, but it's not going to be 100% accurate because it's giving us information from a particular area. So if you look at this echo, if you look at this scan line, where the sonographer is saying, okay, I want to sample velocities from that pathway, right? But there's no gate along that scan line. So we can't pinpoint and say to the system, hey, I only want you to pick up velocities from this particular range, right? It's giving us from that whole scan line. So it's not really going to be that helpful for the exams that we're using Doppler for, but for your registry, you have to know that this would be your last step if you cannot correct for aliasing with the previous 4 steps. Okay, so color flow Doppler. So this is us just using our color. We're not using our pulse wave Doppler, so we're not looking to measure an actual velocity. So this is going to provide us information on the location of blood flow. It does use that pulse ultrasound. It has range resolution, and it's still subject to aliasing. So you're probably saying, well, we just said aliasing was for pulse wave Doppler. You can still get aliasing. You can still get velocities that go past the speed limit of our color flow and represent aliasing in a different way. So it's giving us an average velocity. The color flow Doppler is going to report average or mean velocities, and then pulsed wave or continuous wave Doppler is going to report peak velocities or precise measurements from our pulse wave Doppler. So when we're using just color flow, we're saying, hey, that there's movement in this area and it's traveling in a particular direction. When we're using pulsed wave Doppler, we can say, okay, I'm getting a visual waveform. I can actually measure that velocity in this region. So as you guys know, we use the two hand in hand. We put our color flow on first, and then we put our pulse wave Doppler on that color flow. So color maps, really important. This is known as our lookup table that's used to convert velocities into colors that appear on our image. On the side of our image, we have a vertical bar that has a variation for colors. Most commonly, we see red and blue. There are also 2 types of tables. So we mainly use velocity mode, but there's also variance mode, and that's taking it a little bit of a step further. So velocity mode is providing us the flow direction and velocity depending on the color. So like we just said, there's a vertical bar on the side, right? The middle of the bar you'll see is black. There's a little skinny black line. And that represents that if we see black when we're using color flow, there's no Doppler shift. There's no change in frequency. Now, anything above that black bar or above that baseline is going to be representing flow towards the transducer. So that color is going to be representing anything that's traveling towards us. Whereas below that black line or that black bar in the vertical bar is going to represent flow away from the transducer. So whatever color is associated above that baseline is traveling towards the transducer. Whatever color is below that baseline is traveling away from our transducer. Now, the closer our color gets towards black, when we're talking about velocity mode, is representing a lower velocity. And whatever color becomes really saturated in either direction, so really above the baseline or really below the baseline, is going to be a higher velocity that we're picking up. Now, variance mode also does velocity mode, right? So the saturation of the color above the baseline or below the baseline represents either a low or high velocity, but then we also can determine normal flow versus abnormal flow by looking at the colors side by side. So no longer just above baseline, below baseline, we're also looking at colors side by side. So the colors represented towards the right side of that variance mode vertical bar is going to represent turbulent or abnormal flow. So I don't even think I've worked on a system that has variance mode, but I would be really interested to see what a stenosis or what pathology could represent abnormal flow on a variance mode vertical bar. So really what we're doing is the velocity mode. So this picture on the left-hand side, as we said, very commonly we're using red and blue as our towards the transducer and away from the transducer. Here we have our black bar that represents our baseline, the middle of our color map. That is telling us that there's no change occurring. So if we don't see red or we don't see blue, then nothing's going on, right? But as we get further above the baseline, you see that that red kind of starts to like change to orange to yellow. And then below the baseline, we have a deep, deep blue, changes to light blue the further below the baseline we become, and that's going to represent the range of velocity. So if we're coming in at a really dark blue or a really dark red, in this example, it's giving us a lower velocity. It's representing lower velocity. Whereas if we're coming in at yellow or light blue, it would be a higher velocity depending on that direction. So if we look at our variance mode on the right-hand side, yes, we still have that color map of above and below the baseline, but now we're also adding in colors towards the right of that vertical bar. So we said anything towards the right is going to represent abnormal or turbulent flow. So if we were to see any of that yellow or green, that would indicate abnormal flow in that particular direction. So abnormal flow towards the transducer would be yellow. Abnormal flow away from the transducer would be green. Okay, and color power Doppler. So you're looking at a really small tumor, you're looking at a really small artery, and you just for some reason can't get it to fill, you can't evaluate it. You're going to use color power Doppler. So this is going to show us the presence of blood flow, but it's not going to give us any information on the velocity or the direction. All of the vessels are going to display the same color. So we're not going to have a color map for this. We're not going to have that vertical bar necessarily when we're looking at something in color power Doppler. So the advantage is that the color power Doppler has an extremely low or really high sensitivity to low flow vessels. So it's very sensitive to any motion that's occurring in a vessel. It's also going to be unaffected by Doppler angles because we don't care about the direction, right? We don't care to evaluate what direction that blood flow is traveling in. So it's going to be unaffected by the angle that we're evaluating it in. We're not going to have any aliasing because there's also no velocity information. So there's no speed limit, right? There's no set speed that we're saying to this vessel it needs to travel within. So it's not going to be subject to any of those limitations. Now the disadvantages are we're not evaluating any direction or velocity, so we can't get any accurate information about how that blood vessel is behaving in that area. Also, it's going to have a really low frame rate, lower than color flow Doppler, because of that really sensitive, that really high sensitivity to these low flow vessels. We're trying to pick up the smallest movements, right? So our frame rate is going to be really low because our system is trying to process so quickly. And it's also going to be susceptible to motion artifacts. So you may have seen this in clinical, you may have not have seen this in clinical, but there's a technique called fremitus, where we actually have the patient hum while we're using color power Doppler, and we are using that motion to pick up the vibrations in the tissue. And it's a really neat concept that we use to determine if a vessel or if a finding actually has blood flow to it, or if it's just benign tissue. So that's something that we'll kind of talk about as we get more into breast imaging. It's a technique that we use in that department quite a bit. But it unfortunately is really susceptible to motion artifacts. So if you're looking to evaluate a really small artery and your patient is jittery, or your patient sneezes or coughs or is talking, we're going to pick up that motion using color power Doppler. So Doppler artifacts, as we said, aliasing is going to be a really big one, but there are some other artifacts that we need to be aware of. Ghosting and clutter, this is going to be caused by low frequency Doppler shifts caused by muscle movement or any type of motion. Ghosting is artifacts that's visualized within the color Doppler, and clutter is the artifact that's visualized on our spectral display or analysis. So it's the same concept. It's still those low frequency Doppler shifts caused by motion, but depending on how you're looking at it, if you're using just color, it's going to be ghosting. And if you're using Doppler, it's going to be clutter. We can reduce this by using a wall filter, which is a form of rejection. But we usually don't resort to that. We'll adjust our scale first. We'll adjust our gain if it's color. So we don't really use a wall filter too often, but that is what we would use a wall filter for. We also have crosstalk, which is a type of mirror artifact that we can only see when we are doing color Doppler. So on our spectral analysis, it appears as an identical waveform both above and below the baseline. So if your vessel is truly a positive Doppler shift and you have crosstalk, it's going to appear the same on the top and the bottom. So you may say, oh my gosh, wait a minute, is this actually traveling towards the transducer, or is it really traveling away from the transducer? I can't tell because it's going in both directions. So that is something that we would want to be adjusting our Doppler gain. We want to decrease that Doppler gain. Our Doppler would be set too high. So if we look at this picture on the left-hand side, this is just our color Doppler, just our color, and we are getting this kind of bleeding artifact coming through. This is going to be our ghosting. So it's kind of like picking up a signal outside of the vessel when we know that that's actually this is not true blood flow, right? That's just going to be an artifact. And then we can clear that up and clean that up with our wall filter to get it nice and within the lumen of the vessel. And then if we look at our Doppler on the other side, this is going to be our crosstalk up here. Our Doppler gain is set too high, so we would decrease that to get rid of all of this waveform below the baseline. And we would also clear up this spectral window in that true positive Doppler shift waveform there. And the picture on the bottom, this is going to be our clutter. So this is going to be that same concept of the low frequency Doppler shift caused by motion, and it's coming up on our Doppler waveform. So we would just want to adjust for that as well. Okay, so spectral analysis. So this is what we're using when we're using pulse wave Doppler, right? This is what we can visualize the waveform on. This is what we can measure the waveform on. This is what we can adjust our waveform to fit the parameters better. So there are really kind of two types of spectral analysis. And we're usually using our fast Fourier transform, but you're going to start to see more places using our autocorrelation. So what the difference between these two are, the fast Fourier transform, this is kind of like, this was like the first step of using Doppler with the visual waveform in terms of the spectral display or analysis. So it's a digital technique that's used to process that pulsed wave Doppler signal that we're getting, and it accurately displays all individual velocities in that reflected signal. So we're able to determine if that blood flow is normal or abnormal. When it's normal, our frequencies and velocities are going to be similar. They're going to travel well together. We're going to see a clear spectral window. Okay, we'll talk about what that looks like in a second. And then when we have turbulent or abnormal flow, we're going to see what's known as spectral broadening, or our spectral window starts to become filled with these chaotic frequencies being displayed in that waveform. Autocorrelation is going to be less accurate than the fast Fourier transform, but it's going to be faster, and it helps us to analyze the color flow Doppler only. So if we look at this example here, we actually have both, in the pictures towards the right-hand side, we actually are using kind of both techniques, but the autocorrelation, if you guys see this like blue little line above our waveform, right? That's our autocorrelation. So it's kind of like trying to predict how that waveform is going to behave. And we're starting to see more places use this information, but I don't know if anyone has ever used just autocorrelation on its own. I think a lot of systems are still programmed to use the fast Fourier transform with the autocorrelation application added to it. But if you see that, like that blue trace line and how everything kind of auto populates when the technologist uses that, that's going to be that autocorrelation. I'm old school. I like to make sure that the information that I'm getting is accurate and is as true as it possibly can be. So I don't really use that often. I don't really actually use that ever. I have used it before, but it's not something that all of the technologists out there are using yet. So the things that we want to be aware of when we're looking at this, we just said spectral broadening and a clear spectral window. Now, when we're looking at our waveform, those are going to represent normal flow versus abnormal flow. So if we're looking at our waveform on the right-hand side, this picture on the left-hand side is just an example of that fast Fourier transform. This is how it processes waveforms, right? Nothing too crazy with that. But if we look at the waveforms on the right-hand side, this red arrow, see how it's pointing right to that kind of black region of the waveform there? That is a clear spectral window. That area is known as the window. Now, when we start to see some signals coming into that area, that's when we start to question if that flow is abnormal, because that becomes spectral broadening. So here in this area, right, see how we have all of these signals right in there? We're getting some spectral broadening here. Not too crazy, but we don't have a clear spectral window. And then if you look at the example on the bottom, well, there's nothing clear about any of that window, right? It's totally filled with signals. So that's a true case of spectral broadening in that example there, and that represents turbulent flow, so abnormal flow. So that is it for today. A lot of information, but also a lot of information that we've kind of already touched upon before. If you guys have any questions, please feel free to ask. If not, you are all set. And I am here until 4. If anyone does want to come in for open lab, you don't need to email me. You can just kind of poke your head in. Just make sure you have a partner if you're coming. I don't want like one of you to show up and then no one else is here for you to scan. And then every Monday from here on out until our simulations, I believe we'll have 2 more Mondays. You can come in for open lab as well. So other than that, you guys are all set.